So today we have five presenters. So I'm just going to give you a brief overview of what our presenters are going to share with us today. So we have Lorna Gurn from Dublin City University, and she is looking at co-design methods and recruitment challenges in palliative care research. And we have Nicholas Landy from UCD looking at LGBTQ plus patients and palliative care. And we have Aaron Kennedy from Trinity College Dublin, relational nature of decision making between patients with advanced illness and caregivers in palliative care. Then we have Shamira McKenna from Queen's University Belfast on understanding and mobilising rural death literacy across the island of Ireland. And then we have Nicholas Pujol from Trinity College Dublin, looking at towards a shared and supported decision-making model for end-of-life care. So on that note, I'm going to hand it over to you, Lorna, and looking forward to your presentation.
Thanks, Sarah. Hi, everyone. My presentation today is going to be more about methodology than it is about the content of my research, but I'm just going to give some brief context. So my PhD is about decision-making capacity assessment and support for people with cancers that involve the brain in the specialist palliative care setting. And so the co-design study is the final study in my PhD, and it seeks to develop a guideline for palliative care professionals in how to assess and support capacity in that cohort that's acceptable to all stakeholder groups. So co-design methods in general are very practical and pragmatic, but there are some challenges that I have found as a novice co-design researcher, because this was my first time using this method. So just by way of context, co-design methods generally, they're a family of practical approaches to research that seek to develop a solution to an identified problem that's acceptable to all stakeholders involved. And co-design methods are very well suited to specialist palliative care research because there's a shared underlying patient-centered philosophy, where there's a synthesis of lived and learned experience. The lived experience is obviously people with life-limiting illness and their family, and the learned experience being the professionals, the palliative care professionals, and these are equally weighted, so no voice is privileged over the other. But one of the, I suppose, challenges in using co-design in this context is that co-design research often involves very intensive participation over long periods of time, and that's not very feasible often for people with life-limiting illness. So, for example, one of the most widely used co-design approaches that I'm sure people will have heard of is experience-based co-design, and that often requires prolonged participation over up to 12 months, maybe one co-design workshop a month for 12 months. So it's just not feasible for everyone with life-limiting illness. And so for my research, I opted to select a generative co-design methodology. I have a citation for it at the end of the presentation. It's a creative co-design approach, and it focuses on the generation of an artifact by participants. And in this research, I used fictitious vignettes where there were capacity issues arising for people with cancers involving the brain, and I presented them to a group of people with learned experience, so palliative care professionals and legal professionals, barristers and solicitors, and then separately to people with lived experience, so people with brain cancer and their family caregivers. And I asked them, what do you think is the ideal scenario here? What do you think should be done to support this person? And so co-design, the generative co-design is less time intensive overall, because there's one workshop, and the reason that's feasible is because stage one is a separate study. So I did a different study in 2024, which was a constructivist grounded theory study where I did qualitative interviews with stakeholders from palliative care professionals, legal professionals, people with brain cancer and their family members. And then the findings from that study formed kind of a jumping off point for this study where I gave people that information in advance. They could review it before the workshop. So it kind of went towards developing a shared understanding of the problem. And there's also a post-workshop anonymous survey if people are uncomfortable sharing anything in the workshop in front of others. The one workshop is 3 hours long, and that is obviously not going to be feasible for all people with cancers involving the brain. And so some strategies that I tried to use were frequent breaks, stop at any time. A family member can be present, but they don't have to participate. You can split the workshop into two separate workshops, and there's an option for remote participation as well. So I tried to make it as accessible as possible, but it's certainly not feasible for everyone all the same. So what I had anticipated was this very streamlined one learned experience workshop with three palliative care professionals and three legal professionals, and one lived experience workshop with three people with cancers involving the brain and three family caregivers. It is quite a small sample, but co-design studies tend to have a small sample like that. But there were a number of challenges that I encountered in the recruitment process. So for the professionals, I found that they're very busy professionals. Understandably, there were a lot of professional emergencies that led to last minute cancellations. For example, legal professionals having cases in court that ran over, so they had to be in court the next day at that time. Staff shortages in the hospice. And coordinating a time of convenience for everyone was difficult across the legal and palliative care professionals. Some people only wanted to do outside of working hours, weekends, and other people wanted to do during work hours. So it was difficult to coordinate. And then for the lived experience workshop, it was difficult for the people with brain cancer and their family caregivers to find a time of convenience to participate because of multiple hospital and hospice appointments. And there were also very understandable last minute cancellations because of fatigue or nausea. So I found in general it was hard for people to say that they would be able to do the workshop at 2 o'clock on Wednesday because they just had no way of knowing how they would feel at that time. Um, and some people also had a preference to participate only with their own family members. They weren't comfortable talking about these issues in front of people they hadn't met before. Again, completely understandable. And so this is what it actually looked like. This is what recruitment actually ended up looking like in the end. So there were four learned experience workshops. The first workshop actually only had one palliative care professional because there were two cancellations the morning of. Um, the second workshop had one palliative care professional and one legal professional because that was people who could only do outside of working hours and no one else was available outside of working hours. The third workshop was two palliative care professionals. There was a last minute cancellation of a legal professional because of a professional emergency. And then the final workshop had two palliative care professionals and two legal professionals, but one legal professional only joined at the very end as the others left. So it was more like two separate workshops in itself. And similarly, the lived experience workshop, there was three instead of one. The first workshop had one person with cancer and three family members in the same family. They weren't comfortable having other people there. The second workshop had one person with cancer because there was a last minute cancellation from another person with cancer and their family caregiver. And the third workshop was one person with cancer and their family caregiver, which was rescheduled from that previous cancellation because they had been too unwell. And so I have some kind of reflections and implications from this. So there seems to be, in a way, a tension between fidelity to the methodology and the protocol, but the need for a flexible approach. And the flexible approach is needed to ensure that voices aren't excluded, and in particular, to make sure that voices aren't systematically excluded. So if I stuck rigidly to the protocol for the lived experience workshops, it would be the people who were most unwell, who had the highest symptom burden, who would be excluded from participation because they had to cancel last minute and reschedule. So the approach that I took was as inclusive as possible, facilitating participation instead of excluding on the basis of the protocol. And so this is true to the philosophy of co-design while deviating from the strict protocol or procedure. So that's all I have to say on this. I have some references at the end. The first reference is just about co-design, different types of co-design in palliative care. I found it quite helpful. And then the third one is about the generative co-design framework, although that paper isn't specific to palliative care, but I'm very happy to answer.
Good morning, and thanks for the opportunity to present. So as I said, my name is Aaron Kennedy, and I'm a PhD candidate in Trinity College Dublin. And I suppose the overall focus of my research is looking at how patients and their caregiver approach decision making in specialist palliative care. And I suppose more specifically, I'm interested in how patients with advanced illness and their caregiver navigate decisions around treatment and care, maybe together or separately. So I suppose then This PhD sits within a wider program of work on decision making in palliative care, where there's four PhDs, and then mine focuses on the relational nature of decision making between patients and caregivers. So today I'll kind of be presenting on my first main output from the PhD, which is a published systematic review and narrative synthesis. So I suppose this paper helped me establish the evidence base for my PhD and kind of informed the direction of my qualitative work that's kind of ongoing now and following on. So I suppose just a bit of context on the problem. So as I mentioned, this project is concerned with decision making in specialist palliative care, where decisions about treatment and care are often complex, emotionally sensitive, and made under conditions of uncertainty. So the key issue is that patients with advanced illness rarely make decisions in complete isolation, and caregivers' involvement kind of differs in direction, whether it's directly involvement or indirectly. So they may provide emotional support, they might advocate for the patients, they might manage coordinate of care, or sometimes they might take a more active role in the decision making when the patient becomes more unwell. And so then I suppose the gap that I'm interested in is not simply that whether caregivers are involved or not, because we already know that they are. It's more of a question of how this involvement happens and how it varies between the patient and caregiver dyads and how it's shaped by patient preferences, choices, autonomy, and care. And then I suppose this is particularly relevant then in specialist palliative care, where decisions are often made at times when illness is progression, emotions are heightened, and time can be very limited. Um, so then this slide is just the aims of the public systematic review. So the primary aim was to explore the relational nature of decision making between patients with advanced illness and their caregivers in palliative care. And then the second was to identify decision making styles or approaches between patients and caregivers. So I suppose this was important for the PhD because the review allowed me to move from a broad focus of decision making to a more focused understanding of patient caregiver relational dynamics. And it also helped identify areas which needed to be explored more deeply in my qualitative phase of my PhD. So that's why a systematic review and narrative synthesis was undertaken. And I suppose the systematic review was appropriate because the aim was to comprehensively identify and synthesize empirical evidence on patient caregiver decision making. And then we wanted to include studies that were methodologically diverse, so including qualitative, quantitative, and mixed methods. And then the idea of the narrative synthesis was we didn't want to pool numerical outputs, but we want to kind of identify patterns and relationships across the literature. So the search was conducted across six databases, and the time frame was from January 2004 to September 2024, which meant that we captured evidence over 20 years and it remained focused on contemporary palliative care practices. And I suppose the eligibility criteria was reviewed to kind of keep a focus. So studies had to be empirical, peer-reviewed, published in English, and focused on decision making between patients with advanced illness and caregivers in palliative care. And I suppose this is important for the review because it wasn't just about patient decision making generally, but it was specifically about that relational decision making process. And then we undertook screening and extracts were conducted using Covidence. So records were individually screened and then full texts were reviewed by a secondary reviewer to strengthen the transparency and reliability of the process. And then quality appraisal used the mixed methods appraisal tool, which allowed for studies with different designs. And then the Prisma on the right shows the flow of the studies, where we started off with identifying 4,818. And then after removals from screening and duplicates, we were left with 38 papers across 20 countries. So I suppose overall the review was methodologically important because it provided a systematic and kind of transparent, informed evidence base for the PhD, and it kind of gave confidence then moving on to my qualitative phase of the project, which is currently being developed. And then I suppose the key findings or the key themes from the review was the first was awareness and communication, and this showed that patients and caregivers had a shared understanding of illness and were able to communicate openly. Their preferences were more likely to align. However, when they avoided or lack of disclosure, this could delay decision making. The second then was caregiver influence, caregiver role and influence. So caregivers often act as advocates and coordinators of care, but their level of influence could change depending on illness severity, dependence, and then the practical roles of day-to-day caregiving. And then the third was decision-making styles. So the review found that patients, um, the decision-making styles or the patients and caregivers did not follow one single model of decision-making. So some patients made decisions independently, others preferred shared decision making between the patient and caregiver, and some were guided by patient or caregiver preferences. And fourth was emotional hypocrisy and strain. So patients often supported each other emotionally, but they could also protect each other, which led to avoiding difficult conversations, which then created additional strain. And finally, we had place of care and end of life care. So decisions around preferences for place of care or death were strongly shaped by communication, caregiver capacity, service availability, and then emotional readiness. So I suppose overall, these teams kind of showed that decision making is relational, dynamic, and context dependent rather than a one-off simple process. So then how did this kind of contribute to my overall PhD? So this was the first way that helped refine my research question by showing that patient caregiver decision making needs to be understood as a relational process rather than individual. Secondly, then it helped refine my study aims by looking more at caregiver influence, communication, emotional protection. And then third, and kind of most importantly, it informed my interview guide for the qualitative phase. So the teams of the review helped me develop my questions around caregiver involvement and decision-making roles. And then finally, it justified putting focus on specialist palliative care, where the review showed that palliative care decision-making varies across settings and systems. So the focus on specialist palliative care allowed the PhD to be examined where dynamics are more specific and context coherent. And then I suppose the implications for practice and research was to first to highlight that we need to recognize caregivers as important partners in decision making. Secondly, it showed the importance of supporting open conversations between patients and caregivers and healthcare professionals and avoidance of lack of mutual disclosure or delays. And then third, it suggested that healthcare professionals need to balance caregiver involvement with patient autonomy so that caregivers can provide vital support, but they're also at risk of being overridden or overburdened. And fourth, then we need to develop decision support tools that do not focus on the individual but the patient caregiver dyad. And then finally, it needs to point to training for healthcare professionals in managing complex caregiver decision making in palliative care. And then this is just the acknowledgements to my research supervisory team, the collaborators of St. Francis Hospice, and Professor Karen Ryan, Professor Carl Walsh, and David Mockler from Trinity, and then my funding from the TRDA, and that's all. Thanks very much for.
Yep, so hi everyone, my name is Shamira and I'm a first year PhD student in the School of Psychology at Queen's University Belfast. Today I'm going to be presenting what I'll be doing in my PhD over the next 2.5 years or so. My research focuses on understanding and mobilising rural death literacy across the island of Ireland. So just before I begin, I did want to highlight that this project is committed to embedding personal and public involvement at each stage of the research cycle. So for example, to inform my first study, I had met with representatives from rural and palliative care organisations, as well as had conversations with relevant academics. Some of the organisations can be seen on the right-hand side there. Along with this, I was awarded funding from an internal university fund to recruit a 4-member PPI group to the project, and this will just be members from rural communities across the island of Ireland, many of which who have had experience caring for somebody at the end of life or have their own personal experience living with a serious illness. So first of all then, what is death literacy? Death literacy is a relatively new term, and broadly speaking, it refers to the practical knowledge and skills that allow people to gain access to, understand, and make informed choices about end-of-life care options. So people with high death literacy will have context-specific knowledge about the death system in which they live, and the skills and the confidence to put that knowledge into practice. Researchers highlight 4 key components of death literacy. The first being knowledge. So this refers to the factual understanding of the death system and end-of-life care planning. So this can be things like wills, advanced care planning, or knowing about the power of attorney. Skills then refers to putting that knowledge into practice. And these can be practical and interpersonal skills. Practical skills can just be things like being able to care for somebody at the end of life, doing those practical tasks. And interpersonal skills refer to having the confidence to navigate conversations with healthcare professionals or even family and friends about not only your own end of life care wishes, but being able to advocate for somebody that you're caring for. Thirdly then is experiential learning. So this is learning that comes from providing that hands-on care at the end of life, and researchers have really found that this experience is a transformative one that moves away from simply learning about end of life through books and information, etc. Lastly then, this sort of accumulates into social action, and this is when high death alert individuals come together in communities, and the communities can then use death literacy as a collective resource rather than just an individual one. So why is death literacy important then? So over recent decades, societal norms and attitudes towards death, dying, and caregiving have shifted. This could be partly due to the increased medicalisation of death. And this is where the responsibility to care for the dying person is seen as belonging to hospitals, hospices, and medical care staff rather than the public or local community. And with this shift, people are becoming less familiar with death and dying, and they are losing their confidence in navigating these things. And this comes at a time when we do have a growing ageing population, especially within rural communities. Rural communities on the island of Ireland have the highest average age profiles, so this will disproportionately affect them. And what death literacy does is it empowers entire communities to get involved in death, dying, and caregiving, and to support those who are caregiving at the end of life. And this ensures the continuity of care. So what do we actually know then? We do know that rural communities face health inequalities which are heightened at the end of life. For example, this Hospice UK report outlined things like lack of healthcare staff, longer travel times to hospitals, financial burden, all these things which make dying in a rural area particularly difficult, and particularly difficult for those caregiving as well. In terms of what predicts death literacy, we know that these socio-demographic characteristics like being a widow, being older in age, being a woman, having professional healthcare experiences, holding religious beliefs, and having dependent children all significantly predict higher death literacy, but they don't explain much of the overall variance in death literacy scores. And the strongest and largest, most consistent predictor of death literacy is the previous personal experience with death and dying. So again, back to that transformative learning. So a UK-based survey found that the UK population sit in around about the mid-range point for death literacy scores. And the same survey also found that living in a rural area was a significant predictor of death literacy. And a recent Island of Ireland survey found that this population also sat in around the death or the mid-range point in death literacy. However, the survey sort of found that we were sitting slightly higher than all the other countries that have been previously examined for death literacy. So it sort of shows us there that we do have a wee bit of a way to go because we're still sitting in around the mid-range point. This is just a very brief overview of my PhD then to try and fill in the gaps. So the first study will be understanding rural death literacy on the island of Ireland using a mixed methods approach. As I previously said, a lot of the research at the moment is really centred around the individual levels, those socio-demographic characteristics, and they don't really explain a lot of the variance in death literacy scores. So the aim of this research is to move from the individual level to the community level through investigating the role of social capital in death literacy development. And by doing this through a mixed methods approach, we can understand the what, so what actually predicts death literacy, as well as the how, so how it actually develops over time and through experiences. The quantitative element of the mixed methods study will be a population level death literacy survey in rural areas across the island of Ireland. So this is open to anybody 18 years or older living in a rural area on the island of Ireland. And we're hoping that this will develop our understanding of the levels and predictors of death literacy within the rural population. The qualitative element of the study then is going to be some semi-structured interviews to understand rural end-of-life caregiving experiences and how then death literacy develops through these experiences and over time. And these will be open to anyone 18 years or older who has current or previous caregiving experience at the end of life, and somebody, or they have to be from a rural area as well. So this will look at how death literacy was developed by their caregiving experiences. Lastly then, for studies 2 and 3, the mixed methods study will really form the theoretical basis for these studies. The first aim is to organise a series of public engagement events in one border rural community on the island of Ireland. And this will be to identify and map community assets and to establish the needs within the community. And then study 3 will be working closely with that rural community to co-design a compassionate community initiative to mobilise death literacy, and we will be evaluating this using contribution analysis. And a compassionate community is simply just a network of death literate individuals. And just a little take-home message then. Someone with a terminal illness will spend just 5% of their time in direct contact with formal healthcare services. So the public health approach to palliative care and really the compassionate community approach as well is emphasising that we are responsible for the other 95%. Thank you very much for listening.
I hope you can hear me properly. So my name is Nicholas. I'm French. I have been working in France as a clinical psychologist for over 10 years in the palliative care team. And I am currently conducting a PhD in Trinity College. It's part of a research program on decision-making in end-of-life care. And I am currently at the end of my second year. So I'm halfway. True. So the question I'm trying to explore through this PhD is how can we achieve shared and democratic decisions in end-of-life care So shared decisions between patients, their caregivers, and the healthcare professionals. I don't know if Jane is. Okay, perfect. So shared decision making in my theoretical framework is a practice of deliberation. And the idea of shared decision making is to reach consensus, or when consensus are not possible, to reach compromises between the patient, the family, and the healthcare professional. It is very important to reach consensus and to reach compromises, as action bind people together through care. If patients, family, and professionals may disagree sometimes about one particular course of action, they have to take shared decisions, because they will be involved morally in the decision that will be taken. But this practice of deliberation is very complex in end-of-life care for several reasons. It is complex because of asymmetries of power in the relationship between the patients and the professionals. Some patients may internalize forms of submission, such as deference to medical authority or desire to be a good patient. And there are asymmetries of power also within the healthcare team. For example, nurses or care assistants may struggle to challenge the opinion of a senior physician. But if this practice of deliberation is complex, it's as well because patients are vulnerable and fragile for different reasons. Opioids, pain, fatigue, delirium, ambivalence, sometimes feelings of uselessness, erosion of personal identity. All those factors undermine their capacity to engage in the practice of deliberation. So if shared decision making is an ideal in palliative care, it cannot be fully reached without appropriate forms of support. So the ambition of my thesis, of my PhD, is to develop normative frameworks that will integrate together forms of shared decision making and supported decision making, which are always conceptualized as two separate frameworks. So the ambition is to try to integrate them together. And to do so, I am conducting both clinical and philosophical inquiry in order to explore lived experience, to examine how decisions are actually made, to investigate relational and organizational realities, and to clarify philosophical concepts such as autonomy, deliberation, democracy, and so on, in order to develop normative frameworks of shared and supported decision making. I just want to highlight very quickly what I mean by clinical inquiry. Clinical inquiry is qualitative inquiry method in which the researcher is not a neutral observer, but presents himself as a clinician researcher. So when I introduce myself to participants, I introduce myself as a PhD student and as a researcher, but also as a clinical psychologist, which is important as their participation has to be driven by the idea that by participating, the situation itself might evolve and transform. So we are seeking in clinical inquiry for a transformation of the situation. And clinical inquiry is a case-based approach. So when I analyze data, I analyze them by cases. I have recruited 8 patients from both sides of St. Francis Hospice. Patients come from either inpatient units or community palliative care team, or from the outpatient service. And for each patient, I have included 2 or 3 healthcare professionals, and when it was possible, ideally 1 family member, in order to gather different perspectives around the same case. So altogether, there are 30 participants. And finally, just wanted to highlight an article that we've been publishing along with my 2 supervisors, Geraldine Foley and Linda Hogan from Trinity College. It's an article that basically tried to draw the foundations of the model I'm aiming to build. So the article was published in the journal Medicine, Healthcare and Philosophy earlier in March. Thank you very much for your attention.
At the end of my master's in psychological science at University College Dublin, my thesis is progressing. I'm deep in the data analysis at the moment. So this is more of an introduction to, I suppose, what I'm trying to achieve. So if you want to move on to the next slide, Jane, I'll walk you through what I'm up to. So my thesis is about LGBTQ plus inclusion in hospice and palliative care, but specifically about what hospice provider websites communicate before a person ever speaks to a member of staff. So the idea behind the title, The Digital Front Door, is that a website is often the first place that a patient, partner, caregiver, family member, or chosen family member goes when trying to understand the service. And that first contact is not neutral. It can either increase uncertainty or begin to communicate safety. We all know that palliative care is supposed to be person-centered. It's concerned with quality of life, relief of suffering, and support for people with serious illness and those around them. But the literature does show that LGBTQ plus people can face quite specific barriers in healthcare, especially at the end of life. And these include fear of discrimination, invisibility in policies and documentation, misgendering, uncertainty about privacy, and anxiety about whether partners, close friends, carers, or chosen family members will be recognized. One of the main theoretical ideas shaping my project is minority stress. I'm quite passionate about overcoming minority stress where possible. So minority stress refers to the additional stress experienced by anyone who identifies as stigmatized or marginalized. And in healthcare, minority stress can mean that a person approaches a new service already alert to the possibility of bias, rejection, or even erasure. And in palliative care, that matters even more because people are often making contact at a really vulnerable point in their lives. So the diagram on this slide shows the basic problem. Experiences such as chronic social stress, anticipated discrimination, and the erasure of chosen family can reduce trust and delay engagement with care. And a hospice or palliative care website cannot solve all of that, we know that, but it can send really important first contact signals. It can name LGBTQ plus people, use inclusive language, recognize chosen family, explain privacy clearly, and direct people to relevant supports. So the research question is, do Irish hospice websites visibly communicate safety, recognition, and practical relevance for LGBTQ plus people? The thesis is not asking whether services intend to be inclusive. It is asking what a person can actually see when they arrive at the public-facing material, and that distinction does really matter in the context of this study. Jane, if you want to move on to slide 2, please. Thank you. So the second part of the project is all about inclusion, all about how inclusion can be assessed in a systematic way. So one difficulty in this area is that inclusion can become quite vague. And a website might say, we welcome everyone, or it might have a general equality statement, but that doesn't necessarily tell LGBTQ plus patients whether their identity, relationship, privacy, or decision-making needs have been thought about. So for that reason, the study uses an LGBTQ plus inclusiveness checklist. This checklist was adapted from an earlier inclusiveness scale, which was developed by Dr. Monica Pilch at UCD. I worked with Dr. Monica Pilch in some Irish work on advanced care planning resources. So I've taken that inclusiveness checklist and refined it for hospice provider website communication. Within the checklist, there are 5 dimensions. So the first is affirmation and identity safety. And that looks at whether a website can explicitly names LGBTQ plus people, uses inclusive and non-assumptive language, and communicates respect for chosen names and pronouns. The second is relational legitimacy. And this is especially important in palliative care because the people who matter most to a patient may not always fit traditional assumptions about spouses, children, or next of kin. So this dimension looks at whether chosen family partners, friends, carers, and trusted decision makers are recognized on the website. The third dimension is structural and legal inclusivity. So this applies to the Irish context. And in the Irish context, this includes privacy and disclosure, gender recognition, rights and signposting to LGBTQ plus advocacy organizations. These details matter because people might be asking who will know this information, how's it going to be recorded, and who will be allowed to participate in my care. The fourth dimension is minority stress responsiveness, and that looks at whether the website acknowledges discrimination, fear of being outed, emotional safety, and the need for targeted support. And then the last dimension, the fifth one, is community inclusion. So this asks whether LGBTQ plus communities were involved in developing or reviewing resources and whether there are visible feedback routes for ongoing improvement. So each of those dimensions has a set of criteria underneath them, which are going to be rated from 1 to 5. So 1 being not inclusive, 5 being fully inclusive. The score is not the whole story, though. The ratings are really designed just to create structure, but qualitative notes are going to hopefully preserve some context, and that means that the analysis will be able to distinguish between a brief generic statement and a stronger, more specific signal of safety. So for example, a website might have a general non-discrimination statement, and that would account for something for sure. But it would not be treated as equivalent to a page that explicitly says LGBTQ plus people are welcome, explains that chosen names and pronouns will be respected, their chosen family will be recognized in care planning, or even gives clear information about their privacy rights. So the checklist is therefore designed to capture degree and quality, not just presence or absence. The checklist was refined through feedback. It was piloted. Myself and another student at UCD piloted the checklist. We reviewed the checklist with my academic supervisors, so Dr. Monica Pilch and Dr. Paul Dalton. And also, I'm quite passionate about PPI as well. So with that in mind, I had some consultation with members of the Irish LGBTQ plus community, which was facilitated, thank God, through LGBT Ireland. They were really helpful. So that community input did not create a separate participant data set, but it did help me make the tool more grounded in what may actually communicate safety and trust. Jane, if you want to move on to the last slide, please. So there's 2 tracks to the study. So the study uses a qualitative content analysis design. The unit of analysis is the public-facing website or hospice-specific web page, rather than the patient, staff, or internal organizational documents. The sample includes 17 hospice provider websites or hospice palliative care specific pages across the island of Ireland. That list was drawn from the Adult Palliative Care Hub Services Directory. The focus on hospice provider websites came about to make the sample more comparable because dedicated hospice websites, hospital pages and broad directories don't all communicate in the same way. In data collection, the study will review the the study reviews the sections where inclusion signals are most likely to appear. So I'm focusing on home pages, about pages, mission and value statements, patient and family information, referral information, privacy or complaints pages, equality and diversity statements, and pages that relate to family carers, advanced care planning, rights, or support. So all of that content is going to be recorded, which is painstaking because it involves lots of screenshotting, but I need to make sure that I have all of that archived or saved in case anybody needs to review the data later on. And obviously the websites may change over time, so I need to have that snapshot of what they look like right now. The analysis, like I said, has two tracks. So the first is that directed content analysis. This is where I'll apply the 5-dimension checklist to each website. I'll record evidence such as explicit LGBTQ+ references, chosen family language, pronoun or name respect, privacy information, and advocacy signposting. And that track will give a structured way to compare websites without reducing the project to just a simple word count. The second track is a reflexive thematic analysis, which is going to look at how inclusion is communicated. Is it prominent? Is it buried? Is it explicit or implied? Does the tone feel affirming? Is it administrative, cautious, or even absent? Are there silences where LGBTQ+ concerns might reasonably be expected to appear? So that dual approach is important because I'm not just trying to turn inclusion into a numerical ranking. We know numbers can show the patterns, but they don't fully explain what the communication feels like to someone looking for care. The qualitative layer is going to help interpret whether a website creates a sense of recognition, leads people to infer inclusion for themselves, or unintentionally reproduces uncertainty. The practical contribution is that the findings should be useful for healthcare workers and service providers. If a website does not name LGBTQ+ people, that can be changed. If family language assumes only biological or heterosexual relationships, we can broaden that. If privacy around sexual orientation or gender identity is unclear, that can be made explicit. Or if chosen family is not recognized as services, can explain how patients can identify the people they want involved. For future research, the methodological point is that public-facing communication can be studied as meaningful data. Websites are not just background information, they're part of how services present themselves, and they can reveal both explicit commitments and quieter absences. A really important point to make is that this thesis is not about criticizing individual services for the sake of it. It's about asking how hospice and palliative care can better communicate the inclusive values that we know they aim to uphold. So at end of life, people should not have to search for clues that they belong. And inclusive communication at first contact can reduce uncertainty and really make equitable palliative care more reachable. And that's the aim of my thesis. That's me.
Thank you so much, Nicholas. That was absolutely fascinating and really kind of novel way of looking at inclusivity. I'm just going to ask a question myself because I know we're running short on